Dr. Faries is the co-director of the melanoma program at Angeles and has been an investigator and involved with the melanoma paradigm for as long as I've known him and before. So please come up. Thank you.
All right. Hi, everybody. So I've been in sort of the presentation mode in various challenging situations before. I've had to debate, sort of giants in my field and this open debate. I've had to follow Nobel laureates, in their presentations, and I would say that this is probably the toughest act to follow. The three people here calmly, clearly elucidating various components of the meaning of life, and now you got me coming up. And I guess I can just then learn the lesson that they try to teach in the last segment, and just be, I guess, grateful for this moment that I've been given. And I think it is a great moment, and hopefully this talk, which is a sort of potpourri of interesting tidbits, I guess, will hopefully stimulate questions and interest for when we all are here to answer questions in the next segment. So I'm supposed to cover what's next, and the areas that Dr. Hamid gave me to cover are the microbiome, your T cells, and then some lifestyle issues. And so we'll hit those and talk about how the microbiome, the organisms that live with us and in us, how that relates to cancer in various ways, and implications for some of the current therapies. Some information about T cells, some of which you've heard already, that I'll talk about a little bit again. And then some issues about prevention, about the issue of smoking and the issue of obesity as it relates to melanoma. So the microbiome, as it turns out, this bag of whatever this is up here, is mostly not human. We're only about 10% human, and we're 90% other things. And so if you look at that in terms of just the number of cells that make us up, or even more impressively, the number of genes that are within us, it's mostly not person stuff. It's mostly the microbes that live on us, that live in us. And so it's not unexpected then that these things could have a huge influence on what happens to us over time. And so there are microbes that can cause cancer. So HPV will cause cervical cancer, head and neck cancers. H. pylori can cause certain gastric cancers. Merkel cell polyomavirus causes a skin cancer called Merkel cell carcinoma, and the hepatitis viruses can cause liver cancer. So these microbes can be potentially dangerous, but they can also help us. And so you've heard about some of the microbes that are actually being used as cancer treatments. And one of the oldest of these is BCG. BCG is a TB vaccine. It's been around for a long time. It's used to treat bladder cancers, but we use it in some instances in melanoma as well. And I don't know if this projects very well, but this is the thigh of one of my patients, and you may be able to just make out there are hundreds of little black dots there that are in-transit melanoma metastases. And so we actually injected some of those with BCG, and the interaction of this organism with my patient's immune system led to lots of inflammation at the sites of the injections, and we obviously couldn't inject all of these hundreds of spots, but then they all went away. So this is her. The little black spots that are left are now just pigment, and they disappeared. And it was this interaction between the patient, her immune system, and the microorganism that we put in there that essentially helped her get rid of the melanoma that was there. There are more modern versions of a similar sort of thing. So the Coxsackie virus, you heard a little bit about, that's in clinical trials now. And another patient who had melanoma in transit metastases on his scalp. And now it's in combination. This is given in combination with some of the immune therapies that you get. And as with many immune therapies, it takes some time to get going. You see that his tumors grew actually over time, but then he turned the corner and they all went away and have stayed away. And so we don't understand how this interaction works in any great detail, but certainly for some patients, the organisms can help get rid of things that you want to get rid of. It also affects how our bodies react to the other therapies that you get. And some of the main interest now is on how the organisms that are part of our microbiome influence how well people respond to various therapies. And it's probably actually true of not just immune therapies, but chemotherapy and other things like that. But specifically for some of the drugs that some of you have gotten, for example, the PD-1 inhibitors, they've looked at this. So this is a study from MD Anderson. There are studies from the University of Chicago that show very similar things. And what they did is they sampled the tumor, they sampled the microbiome, the oral bacteria and the fecal bacteria at various points during these people's treatment. And then there are incredibly sophisticated ways now that they can look at the genetics, basically, of the bugs that are there to try and figure out at least what types of bugs, what categories of bugs are living in the GI tract and such. And they can sort of map that out based on the genetics that they find in the samples. And when they look at, this is a measure of the diversity of the bugs that are in the GI tract. And it turned out that people that had a greater diversity, a greater number of different types of organism in the GI tract were more likely to respond to the immune therapies than people who had sort of more simple, more less diverse organisms. And so when you plot out this survival curve, the group that has the best survival that's at the top has this very diverse, very high diversity set of organisms in their GI tract. And so we don't really know how to act on that just yet, but there's additional research going on to try to sort that out. And these are studies that are open, at least at the time this review article was written, that try to get into how all this works. And so it varies from things as simple as adding a half a cup of beans a day to a regular diet and looking at what that does in the diversity of organisms in the GI tract, to things as sophisticated as fecal transplants, which are now used to treat certain infections, but they're looking at fecal transplants to see if you can take basically the bugs from someone who responded well to immune therapy and give them to someone who isn't responding well to immune therapy and see if you can sort of goose the system to get them into a response. So fascinating early on in how this is going, but it'll be interesting to see how this works out over time. Lots of stuff we just don't know. Next up on my list, on my agenda, are T cells. So you've heard a lot about T cells, and most of the immune therapies that you've heard about, that you've gotten, work through the T cell in one way or another and aid the T cell in fighting cancer. You've heard a bit from Dr. Daniels about autologous TILs. I'll talk a little bit about modified T cells that are being used in some clinical trials, and then another type of immune cell called dendritic cells that we're using in the context of a vaccine. So, TIL, tumor-infiltrating lymphocytes, our bodies are generally able to identify melanoma specifically as an abnormal thing. And so the white blood cells can traffic in and get into the tumor, but for one reason or another, they're not able to eradicate the tumor. And so what happens in this TIL therapy is the tumor's taken out of that immunosuppressive environment of the tumor, and you can look in there and you can see these immune cells that are in there that are just not up to the task, but you can take them and you can put them into culture conditions in a lab where those immunosuppressive effects are not there anymore, and where you can support the growth of those immune cells. And they proliferate, they kill the tumor that's in the petri dish, and then you can take them and put them through a rapid expansion protocol. You identify the ones that can kill the melanoma cells, put them through this rapid expansion protocol to generate billions of them, and then those can be given back to patients as an IV infusion. And there are various ways they can be supported once they're given. It's not a simple thing to do, but it does seem to be effective in some people, even if they've been resistant to other types of therapy. And it may also synergize with some of the immune therapies that we have already. And so that's being, there's a trial open at Cedars now from that company, Lion, that's looking at specifically at that therapy. You can modify the T cells. So one of the problems is that whole process takes a long period of time, and you can't always identify cells that are reactive against the melanoma. And so this hasn't been enormously successful so far in melanoma. It's been very successful in some of the lymphomas and leukemias, but you can take white blood cells, the lymphocytes, out of just the peripheral blood, so no need to resect a tumor, and actually alter those cells in the laboratory. So you can introduce genetic material into them that causes them to be specific, to have a specific T cell receptor that can recognize tumor antigens, or what's called a chimeric antigen receptor that's almost like an antibody, and change the cell so it turns into a CAR T cell. Those cells then can recognize either a normal sort of presentation of tumor-specific characteristics of the cell, or an antibody-based recognition of something on the surface of the cell, and kill those cells. So it's been very effective in lymphomas of certain types, those sorts of things. The challenge in melanoma is identifying the targets, and that's been sort of the problem so far, but there's work ongoing to make that happen. The immune system and how it relates to cancer is a very complicated situation, and we certainly don't understand it in great detail. But one of the other components of this interaction are antigen-presenting cells, or dendritic cells. They're the cells that educate the immune system. So they tell the rest of the immune system, the soldiers of the immune system, like lymphocytes, they tell them what to go after. And so another angle to take on using the immune system is to actually use vaccines. And the goal of vaccines in general is to educate the immune system to have it recognize things that are bad for us and get rid of them. That's how it works for the flu, and that's how it works for polio, and the thought is that have it work the same way to fight against tumors of various sorts. And so we actually have a clinical trial that involves dendritic cells, these professional antigen-presenting cells. And the way this trial works is that a piece of the tumor is taken out, it's destroyed, it's lysed, it's broken up in the lab so that it's not alive anymore, and then those fragments are put into empty yeast cell walls, and those turn out to be a very effective way of getting those tumor fragments, those tumor markers, into these dendritic cells, into the antigen-presenting cells, and then those cells are collected and given back as a vaccine. And so that trial is still ongoing, and we'll have to wait and see how well it does in trying to accomplish that goal. What else? So what about lifestyle, and what parts of everyone's lifestyle affect both the likelihood of melanoma and how patients do when they have melanoma. And so 3 things to cover that I'll cover there. There are lots of other things to talk about. One is, what do we know about prevention for melanoma? How does smoking affect how patients do with melanoma? And then what happens with obesity? So in terms of prevention, avoiding sun damage. That's 95 to 99% of it. And for patients that have an existing melanoma, they're absolutely at risk for getting additional melanomas. So even if you get through the first diagnosis and that's treated and taken care of, there's probably in the neighborhood of a 5 or 10% chance that any melanoma patient will get a second melanoma at some point down the road. And so to try and reduce that risk, avoiding sun damage is an incredibly important thing for patients over time. That does not mean you can't be out and doing your normal things. It just means you have to be sensible, you have to be smart, you have to be careful about how you do that so that you're protected and you're not getting additional sun damage. And that's through a combination of picking the right time of day to be out, to be covered up if you can, to use the shade, and then to wear sunblock. You'll know that you're doing what you need to do if your skin basically stays the same color all the time, and you're not getting sunburns. Melanoma patients are also at risk for non-melanoma skin cancers. And so we don't know a huge amount about how to protect ourselves from that other than avoiding sun. People are often very curious about nutrition and how that plays into the risk of cancer. And I would say, broadly speaking, we don't know. That a lot of the things that we think make sense and should work, things like high doses of antioxidants and things like that, don't work, and some are more harm than good. And I often recommend that people are interested in nutrition get their nutrition from food, primarily. The one exception that we know that almost certainly has some impact is vitamin B3. And so this has actually been studied fairly well in a study led from the Melanoma Institute Australia in Sydney. And actually, I think that the winner for longest distance traveled to come to this meeting is Jonathan Stretch, who is Professor Stretch is visiting, I guess not specifically for the symposium, but from Sydney, Australia. But he was here today. And this study comes from his institution. And this is just nicotinamide, essentially niacin, vitamin B3, that is given 500 milligrams twice a day, and decreases the risk of subsequent non-melanoma skin cancers, for sure. We don't know if it affects melanomas, reduces the number of actinic keratoses. The effect only lasts while you're on it, so it seems to go away once you stop taking it, but it's generally pretty well tolerated. Smoking, as it turns out, is bad for you. I know. You heard it here first. But it's specifically bad for you in terms of melanoma. So in patients who are current smokers who are diagnosed with melanoma, their risk for metastasis in their lymph nodes, which is in the table there on your left, is about 30% higher if they're smokers than if they're not. And when you look at long-term survival, that's also reduced in patients who are current smokers. And it seems former smokers actually do about as well as never smokers. And so quitting is probably good, makes good sense for a whole bunch of reasons, but it also makes sense in terms of the melanoma specifically. In contrast, obesity is a mixed bag for melanoma. So obesity has a lot of ill effects for other diseases. And other cancers. In melanoma, it's a little less clear-cut. So obesity is clearly related, at least in men, to the risk of getting melanoma. So that's the figure on the left under men. All of the studies that were done, that's just a list of a bunch of different studies that were done looking at this question, and all the ones where the line is to the right of that vertical line indicate an increased risk of melanoma. So obesity in men, anyway, is related to an increased risk. In women, it doesn't appear that that's necessarily the case. We don't know why that is the case. There are a lot of interesting differences between men and women in terms of melanoma, and this just happens to be one of them. Obesity also, in the lower right, obesity is also related to the thickness of the melanoma, so the risk characteristics of the melanoma, and obese patients tend to have higher risk, thicker melanomas. And it may be because they're undressed less often, but for one reason or another, they also present with worse melanomas. But paradoxically, it does not seem to impart an adverse effect on survival once you're diagnosed with melanoma. The same plot there on the left are a group of studies, and this was the study that Mike Davies did from MD Anderson that combined a bunch of clinical trials for advanced melanomas. And at least for patients who are getting immunotherapies and patients who are getting targeted therapies, the obese patients did a little bit better for reasons that aren't entirely clear. So it's defined in different ways. In both of these instances, it's defined by a body mass index of 30 or greater. And overweight is sort of the next category down from obesity, and that has a less consistent effect. But in that, and then in our own MSLT trial, which was earlier stage patients, the obese patients did a little bit better than the non-obese patients. Now, this is not to suggest that you go out and get obese as a result of it, but it is a mixed picture. Elucidating why this happens will be an important thing to do over time. So, just to bring it all back together again, so the microbiome, these bugs that live with us and in us, are both our friends and our foes, but they probably have important implications in how we respond to therapy. T cells are the army, and there are lots of different ways we're trying to get at affecting them, using them to fight melanoma and other cancers. And then lifestyle, prevention, incredibly important, and sun protection is the #1 consideration there. Smoking, just say no. And then obesity, it's a mixed picture, an increased risk, an increased thickness, but maybe not an adverse effect on survival overall. So hopefully this has stimulated some other thoughts that you might have about some of these issues, about lifestyle, and we'll get into addressing all those in the panel session. Thanks very much.